Good afternoon. Thank you for joining us for our discussion today. This is our Medicaid Town Hall, Ask HMA Experts Anything. My name is Jen Colomonico, and I'm happy to facilitate this discussion with a tremendous group of colleagues. I will just take a moment and introduce them. Before I do, I will answer the question that's always asked, which is yes, we are recording this, and yes, you will get a copy of the recording for having registered for this event. So thank you for that, and we appreciate you sharing this to anyone for whom it would be useful. We will be taking questions as we go along, so please do post them in the Q&A section. We do have a good number of questions that were posed as part of the registration, so we are looking forward to a really great discussion. So let me introduce my colleagues that will be fielding these questions today. Liz Arjun is a trusted healthcare policy expert with deep experience advancing Medicaid and coverage programs at the local, state, and federal levels. Liz has led major initiatives focused on integration, system transformation, expanding access to care, bringing together diverse stakeholders to drive meaningful change. Farah Hanley is a skilled Medicaid professional with more than 30 years of experience shaping policy, delivery models, and financing strategies within Michigan's publicly funded healthcare system. She was the Medicaid director for the state of Michigan and has held other top leadership roles in state government, including a chief deputy of health, and has led major initiatives such as Michigan's Medicaid expansion and health plan procurement. Beth Kidder is a nationally recognized Medicaid leader with over 25 years of experience, including serving as Florida's Medicaid director, where she helped lead that transition to a managed care model. So Beth's experience is deep in Medicaid policy, long-term care, quality improvement. She also previously served as president of the National Association of Medicaid Directors, so has quite a national perspective as well as her Florida experience. Christine Rain is a healthcare operations and business transformation leader with 25 years of experience in Medicaid, Medicare, and CHIP programs, where she's led large-scale initiatives across managed care, long-term services, and special needs plans, including executive roles in both health plans and in healthcare organizations. And Josh Trent has over 15 years of federal health policy experience, including leading roles crafting major Medicaid and CHIP legislation on Capitol Hill, among other roles. Josh is now the CEO of Levitt Partners, an HMA company, where he advises clients on federal policy strategy, including publicly funded healthcare programs from our Washington, D.C. office. So with that, let's go ahead and take down that slide and get to our conversation. Josh, of course, I'm going to start with you because all things start with the budget reconciliation debate that is unfolding as we talk. So right now, maybe the punchline is we don't have certainty, but we certainly know a lot of things that are being proposed and can at least speak to kind of what we know and what we don't know or what we should be looking for over the coming weeks as this resolves itself. So I'll let you get started on those kinds of questions around what's in it, what's not in it, and how can we make some sense of that.
Yeah, thanks, Jen. I think to your point, at a kind of table setting level, it's important to note that while the Senate is voting on a number of amendments as we speak now, working through that today, while this may pass today and go to the House, there are a lot of things that we do know that, so we'll talk with a bit of humility and a bit of certainty, recognizing that we don't have total uncertainty, but we have some imperfect certainty. The things that have gotten a lot of attention relative to the House passed bill in terms of changes, the Senate included changes to modify provider taxes, whereas the House was largely grandfathering provider taxes. The Senate adopted a policy that would reduce the 6% hold harmless for expansion states, 0.5% a year. And I will also say, part of what makes this challenging to follow is there are new iterations of text. And so the latest text we have seen was out Friday night, the 27th. Congressional Budget Office analysis over the weekend. And on the Senate Democratic Budget Committee website, they have some details that are being updated. So they may be a little bit out of date in some cases about what the parliamentarian apparently has said about different provisions. There was a bit of debate about whether or not the provider tax would stay in reconciliation. That did get redrafted. That will stay in. State-directed payments change relative to the House is that for grandfathered state-directed payments, so states that think, hey, we're good, we're okay, it will slowly reduce the value of those state-directed payments from average commercial rate to being in compliance with the new restrictions. The Medicaid policies were largely stripped down compared to the House as far as taking out the dish delay and the Accelerating Access to Kids Act, some other things. The eligibility and enrollment rules, rather than being kind of prohibitions on the regulations, they were bans temporarily through, I think, September 30th, 2034 on the nursing home and eligibility and enrollment rules. I think a big change that we'll all be thinking about a lot more in coming days, assuming it becomes enacted, is the change to have the CMS Office of the Actuary certify that Medicaid 1115, Section 1115 demonstration waivers wouldn't increase expenditures relative than they would have against the baseline. That's a really big change. It's always been the policy of CMS, at least over the last number of years, under multiple administrations, for budget 1115 waivers to be budget neutral, but that's been a CMS calculation, not a CMS Office of Actuary calculation. And I know from a lot of stakeholders when the CMS Office of Actuary had to sign off on Medicaid MCO rates, it was a historically new thing for them to do. They had developed some capacity, kind of institutional muscle internally, and it took a long time to actually get rates reviewed and approved. So that is a bit of a sleeper issue that feels maybe technical, but could be really important in implementation. Um, I think work requirements, largely unchanged. A couple of things change around the edges. The one thing that will matter for health plans and for enrollment brokers and hospitals and for states, there is some language in the Senate bill allowing telephone and text message outreach for enrollment around work requirements. It's currently only drafted to work requirements, not to enrollment verification. But I know a lot of stakeholders have been interested in the FCC waivers under the Biden administration for enforcement related to the Telecom Consumer Protection Act. So kind of wonky issue, but important for friends working in enrollment issues. There also was, the House had an exemption for caregivers or parents of children. That is lowered in the Senate language to those responsible for children, I think 13 or 14 and below. So some of those things getting a bit of attention will matter greatly in implementation. A couple of issues from Medicaid perspective that we know will be litigated on the Senate floor. Also in the Senate is looking at a rural health kind of stabilization fund of about $25 billion. It's been a big issue for Susan Collins, for Josh Hawley, for a number of other members. Susan Collins has an amendment she's been floating, which would make some tax changes to help offset doubling the size of the rural health provider fund. So that will be an amendment to watch. And then Senators Rick Scott and Loomis and Mike Lee and Ron Johnson have an amendment which would sunset the enhanced FMAP for the ACA medicated population, I believe starting in 2030, effective in 2030. That's not expected to pass, I don't think, but just based on where members have been, certainly it's been a sensitivity for the House. But it's something that the leadership agreed to back and bring a vote to as part of, getting political support for the bill. So there's a lot more we can say, but those are some of the things we can know. I think what we've been talking with clients kind of around the clock over the last number of weeks is it's important and understandable to look at the differences between the House and Senate language, but it's really important to look at the similarities and where there's agreement, because even though the details in a category may change, where there's categorical agreement on the types of policies, it really turns to friends working implementation for plans and providers and health centers and states and others to think about, okay, how do we now begin to prepare?
Um, Thank you for that. there's a question about sort of transition periods. I'm pausing because I'm thinking you talked in some ways about, the timeline. They may pass something, but it doesn't go into effect until 2030. But, I guess just generally, how quickly do you see some of these changes being rolled out versus how much time might states have to adjust?
Yeah, in many cases, they'll need to, I'm sure all be helping clients look at what are the dates in the final legislation and map that out. One of the early implementations of a really big policy is the work requirement policy, where this date got moved up for HHS to implement that, and they're looking at guidance. I believe it's by the end of the year, such that it may not even be a notice and comment period. It may be more guidance. And there are a number of things in implementation of that policy, which is one of the biggest policies in the bill that there could be a good bit of state variation in how it's done, but a lot of the guidance and the direction is going to be delegated to the secretary. So that's going to be enormously important for stakeholders to engage.
Mm. Farah, let me bring you into the conversation here and sort of just responding to what Josh just talked about. I know there's some specific questions here about kind of what are the projected cuts in the federal match. Obviously, that's not known specifically yet, but how are you thinking about these issues?
Yeah, thanks, Jen. There are a lot of different variations with financing changes in the reconciliation bill as we see it today. It's not only affecting Medicaid, which it reduces federal funding by $863 billion over 10 years. It does so through so many different mechanisms, including things like changing the financing permissibility for provider taxes, as well as state-directed payments, some of which Josh alluded to. There are also cuts related to the Supplemental Nutrition Assistance Program, or SNAP, and that's by $295 billion over 10 years. So the financing impact is really broad reaching. It also cancels the Future American Rescue Plan Act, which were these incentive payments for states that newly expanded Medicaid eligibility. And the reality is many of these cuts filter straight down the state Medicaid programs. And unlike the federal government, which can run deficits, many states have these constitutional or statutory requirements to balance their budgets. And so what they're looking at is some very large impact to these federal changes, the outcomes of which we've seen research in the CBO has shared that there are going to be significant drops in coverage due to some of the provisions. So you've got policy provisions that'll affect the eligibility, but you've also got the financing side. So on the federal match, really looking closely at the Medicaid and SNAP. And when you think of SNAP, the recent Senate language starts in FY28. If a state has specific eligibility error rates, those percentages of where their eligibility error rate is will drive the state match. So, for example, if a state has an eligibility error rate below 6%, then it'll still be a 0% match to the state. But as that error rate grows, the state is required to kick in more. And it could go as high as 15%. And when you look at states that have SNAP programs of $1 billion, 15% is a lot of money. Again, unlike the federal government, a lot of these states are required to balance their budgets. And so when you're looking at these type of overall financing changes, and I haven't even gotten to the details of the provider taxes and state-directed payments, which could have huge impacts on things like rural hospital access. Those are the types of things that we're really keeping a close eye on and tracking.
So, not surprisingly, lots of questions centered around eligibility changes and how this will roll down. So, thoughts on how you're looking at that, and Beth, also invite you to jump in here as we think about what I guess what leeway states will have to change eligibility, to what extent it's just forced by reduction in funding versus sort of changing to eligibility policies.
I mean, I'm happy to start, but Beth certainly happy to hear her thoughts too. I think when we talk about changes to eligibility, it's not necessarily that there were targeted groups that said you will no longer be eligible, but it's these changes in policies, as you just suggested, Jen, that really result in drops in coverage. So we've heard a lot about the work requirement certification. There are administrative hoops to jump through in order to certify compliance with work requirements. That will result in a drop in coverage, and we can talk about why that is. It's quite broad reaching. Anything from individuals struggling with getting access to the portal, the state portal, in order to comply, from that to not receiving letters in the mail or not paying attention to letters in the mail that said you need to do this. And so you have drops in coverage coming from administrative barriers. There's also things like requiring cost sharing for Medicaid expansion adults. Those are the types of things that we're looking at as well, for if those with specific incomes. Also, things like the shorter certification periods for Medicaid expansion adults. It's currently 1 year, it would be revised down to 6 months. And so when you look at all of those things, as well as I mentioned earlier, the provider tax freezes and the state directed impact, these things are likely to have significant changes and effects in terms of eligibility.
Yeah, and I think, Jen, the other piece of that is, as Farrah's talked to, with sort of the direct impacts of the bill, but states are going to have to balance their budgets, and so there's only a couple of ways to do that in Medicaid. There's actually a lot of restrictions on what states can do, and so their options really are to look at actually making reductions in optional eligibility categories, decreasing income limits, eliminating populations that they cover. So these are drastic types of things. They can also look at optional benefits. Most optional benefits, however, are not a big chunk of the budget. The ones that take the most money are things that are mandatory. So that leaves provider rates, which is traditionally an area where a lot of states go to reduce costs when they have to reduce their budgets. And so that would have a further ripple effect through to providers who might be seeing reduced per unit cost reimbursement at the same time that they're seeing fewer people be eligible for all the reasons we talked about. So it's a double whammy there. But those are some of the things that states can do within the Medicaid rules to try to manage their budgets as they've done in other tight times.
So there's a bunch of questions about work requirements, and I want to go there next. But just to be clear, in some cases, folks are talking about, well, this is really about, able-bodied, the Medicaid, the ACA expansion population, that's really what this is focused on. But as this rolls out, it's not specifically saying only those folks are affected, right? I mean, it seems like it's wider reaching. I mean, how do states receive that? Like, could they just eliminate this one category? Sounds like you're saying there's not enough money there to kind of reconcile with what the cuts that they may face.
I think that's right. And again, just to be clear that this will impact non-expansion states as well. So Florida has over 400,000 people in the categories that could be subject to this. That's not taking into account whether they have a medical exemption or something like that, but just looking at people in sort of that are of the right age in the TANF type categories, or the caregivers of dependent children categories, without knowing the final bill and doing that analysis more deeply. But you have a universe of over 400,000 people who could be impacted, and that's in a non-expansion state. So just to be clear, that even though a lot of the analysis is focused on expansion, there are other impacts in some other very large states. So yeah, I don't know a way to balance it out necessarily when you add up all of the cuts together in the short time period in which most of these will be implemented. It's going to be very hard for states to pivot quickly.
So, lots of questions about work requirements, including some new questions I see popping up. So, and obviously the ink's not dry on any of this, but what should states be thinking about kind of anticipating, you know, regarding work requirements right now? There's a question about how much flexibility states will have. That may not be known yet, but just generally, how should states be preparing around work requirements?
I'm
You
going to
wanna
jump
go
in real
first,
quick.
or
I'll just
go
jump in real quick to answer the question about the timing. There is a requirement in the Senate text that got released on Friday for interim final regulation, released no later than June 1, 2026. So there may be guidance between that, but an IFR then. And it looks like they, if I'm reading this correctly, are exempting it from some of the traditional rulemaking requirements under Title V of the U.S. Code.
So it'll move faster, likely. Yeah.
Yeah, I mean, but changes of these magnitude, they take a lot of time. The systems that have to be changed and the personnel changes that have to happen to staff up for this kind of thing are significant. So there's a lot of things that states can be doing right now and thinking through. One of the things that we've seen from the work requirement implementations that have happened so far, or partial implementation states that started to and maybe didn't complete their implementation, is that automation matters a lot in reducing the burden to the state for administering the program. So every time you have to notify a beneficiary, get information back from them, go back and forth with them, have your call center talk to them, send out notices, get returned mail. All of these things are administratively burdensome, not only to the individual, but also to the state. And so the best thing that states can be doing is thinking about ways that they can be interfacing to get, automated data coming from their Department of Education, for example. Can they tell if someone is in school, or in college to the amount of hours that are required? Can you get things from your labor or workforce agencies that tell you whether people are employed? There are other data sources there too. But those kinds of things, if the more you can think about it, and then also if the exemptions remain, that if someone has met the work requirements through SNAP or TANF, that they would then be, they would also be exempt for Medicaid. Again, you've got to be able to get that information in. So starting to think and plan for those changes, as well as for the changes of more frequent redeterminations. That might mean more staffing, or it might mean, can you think about innovations like chatbots and things like that that can help assist with the workload that will come from that. So those are just a couple thoughts. I have more, but Farah, did you want to jump in on that?
I everything you said, totally agree with. Just a couple other things to add to that. Definitely on the automation piece, the IT changes are significant. States are going to have to invest in these robust IT systems to track compliance, to manage the data, and to ensure that there is a very effective way to the state that can use state wage data, or if there are any trusted sources to see if there are any IT solutions that could work. So the beneficiary doesn't necessarily have to go in and take action every time. Helpful to have any IT really be the strong, where much of the funds get invested in. There's also going to be that state administrative resources and capacity. We hear that a lot about the administrative burden. And so relying on the individuals or groups like community navigators to see if they could really do a lot of this work. The state shouldn't have to be doing so much in terms of communicating with beneficiaries, but there is going to be that investment in helping to pay for others to monitor those activities, process compliance, documentation, that kind of thing. I also want to stress the beneficiary outreach. One of the things we learned in Michigan was when we did the PHE unwind, it was significant in terms of inaccurate addresses. If we don't get their mail, if the individual doesn't get their mail, they'll drop off the program. And so many people actually ignore mail. So we talked a lot about what we could do to the envelope to have them pay attention to it. This is the type of thing that's really important, the beneficiary outreach, because it can be very complicated. And I also want to say, I know we're talking about work requirements in this broader webinar, but this is the kind of thing that we can only spend a webinar on. It's very complex. It is one of the single largest lifts that states can do to implement. And we talk about states, but health plans can play a huge role too, especially when it comes to beneficiary outreach. So relying on those trusted partners to get the correct information out there and ensure that people are compliant and that there are efforts for things like informational sessions, written materials, and that direct communication.
There is a question about the, how all of this will impact state contracts. So maybe kind of I'll go to that question, but you raise an interesting point, right? There may be new requirements expected of MCOs given some of these changes. So I'm not sure who wants to jump in first on
Yeah.
that. I think Beth,
I'd love to
yeah.
take that. I
Please.
think it's very possible that there will be a lot of impact to MCOs because first and foremost, any changes to the base Medicaid program will flow through to the managed care organizations, whether it's benefit changes, whether if rates are being cut, then capitation rates will be impacted. And so those are kind of the direct impacts. But I also think that states will lean more heavily on their managed care organizations to help with these changes because of the sometimes greater ability to contact the members. States may even seek to replace benefits that are getting cut or reduced by asking the plans to provide them as value-added benefits, or try to replace those in some other kind of way out of their margins. And so I do think that there are a lot of impacts that the plans will see, and they will be being asked to partner with the states to try to make up for some of these gaps.
Jennifer, I just wanted to chime in here. I think
Please.
Farah and Beth already alluded to this, but these new administrative requirements, over the last 20 years that I've been working in Medicaid at the state and federal level, there have been back and forths about new requirements and things that are adding requirements, but also simplifying. And we've learned a lot. And so I think, the comment about engaging with MCOs, for example, Farah mentioned people get mail, they don't look at it if it comes from the state. But we've learned that actually if it's coming from the managed care plan or their doctor even, they might open it. So there's a lot of, experience that we can call on. The bottom line is that we know that there's not a lot of funding to implement these new changes. There's not support for states to do it. So we're going to have to all be coming together to figure out how to design, and implement in a way that is going to minimize impacts on beneficiaries and ultimately providers. But we do have a lot of experience about, how to do that. We're just going to have to really pull together and look at that.
While you're off mute, because I was going to go to you next anyway, and I want to come back on the provider question, and I do see there's a couple other questions in the chat right now about that. But talk a little bit, Liz, about children. Obviously, one of the largest group of Medicaid beneficiaries, and it's again, the rhetoric is often that the kids won't be as impacted, but I think we've talked about that. Inevitably you can't guarantee that. So talk a little bit about sort of
Sure.
direct and indirect
Sure.
impacts.
I think one of the things that was really not surprising, but good to see with the Affordable Care Act in the states that expanded Medicaid and coverage was that many of the states saw it was an expansion for adults, but states took advantage of like, oh, let's expand more for kids, and in some states did expand eligibility, but at the same time, all of the outreach and the work that happened resulted in was what we call the welcome mat effect, where parents are getting enrolled and their kids get enrolled. Everybody, the entire family is, engaged with the healthcare system in a new way. I think many folks are really concerned about that reverse effect of what's going to happen when we're changing eligibility rules and requirements for their parents. And for adults. I know there are some protections or exemptions that are being considered in the federal package, but I definitely think kids are parts of families, and so they're going to be affected when their parents are having to face more paperwork requirements and it's not clear. And I think to Beth's point and Farah's point, there's not a lot of places to cut, but kids are a huge part of who's already covered. And you know, that there's not, it's going to be really up to states to figure out where to go. And I'm very concerned about it from that perspective. Anyway, I'll pass it over to Beth. I don't know if she wants to add something on that.
Yeah, I think that's right. Is that we do see that that welcome mat effect, and that if parents get kids are covered, parents are covered, it helps everybody gets covered, right? So we do want to make sure that we're keeping an eye on this. That I want to emphasize that the point that we have learned a lot about this over the years. So even as recently as the public health emergency unwinding of Medicaid eligibility, states tried a lot of new things and a lot of new outreach techniques. Some of them are extremely effective. And so we are not without tools here. And I think the key will be to try for people like us to try to help spread the word about those things that were effective as well as what was most efficient. Because there's a lot of things you can do, but it may take a lot of manpower or a lot of money. Or a lot of time, and those will be in short supply. And so trying to think about those things where you can really get the bang for the buck for what you're doing are going to be important. And I do think there's going to be some technology pieces of that that we're going to have to try to lean into. It was encouraging that Josh mentioned that there may be some more flexibility in, and this may have been even before we started this webinar, but there may be some more flexibility in the kinds of outreach that states are allowed to do with Medicaid beneficiaries, like through text or phone outreach. And I think that is going to be really important because I think cheap channels like that of outreach are going to be really important.
So there's a question that I may morph a little bit. The question specifically is around, whether are there plans at the state level for replacing cuts. I think you've made the point that most states have to balance their budgets. You've also talked about sort of some creativity in terms of how different states might respond. So I guess maybe I would ask the question, what types of what resources, what levers do states have, short of just somehow finding money to replace the cuts, which seems unlikely, but what do you expect to see, or what are you seeing states talking about doing as a response to this?
I'll chime in. I've heard a lot of states are looking, well, you think about where states can go. They can either go to rates, services, or eligibility. And most of them are going to be focused on looking at rates. And so when you think about what that means, they don't want to cut providers. Providers already have low reimbursement rates from Medicaid. What they're trying to do is invest in some sustainability strategies, things like investments in preventive care or care coordination. We're hearing a lot of like value-based purchasing that continues so that they can do as much as they can to insulate themselves from these external factors like rising labor costs, inflation, what's happening at the federal level. It's not enough. So they do need to be broad in where they're looking. It is though one of those things that they're trying to tackle is, what's our list? What do we have available to us? It's not much, but there are places that they're really trying to pull from. So when you think about, enhancing care management strategies, these value-based arrangements, as I mentioned, to pay for, prescription drugs or nursing facilities. They're also looking at various strategies to address workforce shortages and using extenders, especially on the behavioral health side, like community health workers. These things are all good. Of course, then, are you creating more access, which can also be good. However, balancing that against how much money do you have to pay for that access? So, telehealth is sometimes an option too, because it is less expensive than having someone actually go into the doctor. It can be less expensive. But states are really looking to proactively take these recession planning efforts. They're really looking to figure out ways to prepare for future budget challenges. It's not easy. They've got Medicaid program administration, IT expenses, long-term care, prescription drug. I think when you look at the number of prescription drugs per enrollee, I mean, you've got to look at where the high costs are and where the large costs are in order to find the large savings. You can't go to the small areas in the budget. Prescription drugs is usually where states are going to try to go. they will get rebates on those drugs, but there's still very high costs, especially to the health plans. When you think about the number of prescription drugs per enrollee, they've decreased over from like 2017 to 2023. There was a Kaiser Family Foundation report that just came out. So they went down, but the net spending on drugs has actually increased by like over 70%. And so you've got to look at where some of the high costs are in order to find some of the savings. And so I think that might be one place they go to, something like GLP-1 inhibitors, for example. And I know it might sound like I'm kind of going off on a little tangent, but the states are going to have to be going off into tangents, in order to come up with the most creative ways to squeeze dollars.
I agree with Farah. I think, this, as Josh sort of started out this call, there are some things that kind of hold true no matter what. There's going to be a reduction in dollars. There's a small group of people that end up costing the most in in Medicaid. And I mean, the experience of folks that are in that category is often not good. Their care is not coordinated, as Farah said, and there's a lot to be done in terms of making sure that we're delivering better care to them. One thing I know here in Washington State, we just are now implementing a community health worker benefit. That's a way to provide more access to care coordination for behavioral health services. And we know that if we spend more on behavioral health services, perhaps we'll save more money down the line for people not ending up in the hospital for a behavioral health issue. So I think it really, if anything, it's hard to go there because it's really challenging work. But I think that looking at how we can make sure that we're delivering better care at the same time, it really puts the onus on, I think, providers, MCOs, states to really try to, come up with better ways to provide care to those folks who do cost the most. Because at the end of the day, all those costs, it's not, again, the experience of most folks is that in that category is not good, and there's a lot to do. So I think it just puts a stronger emphasis on the need to figure out how to do a better job for these folks.
I want to come back to behavioral health because there's several questions on that generally, but there's some questions about providers and cutting provider rates. So, particularly, I guess we don't exactly know what those cuts will look like, but we know that it's on the agenda. So, what are you thinking that ultimately will look like, and sort of how states? I think there's a specific question about whether. No, that's a different question. Sorry, whether state revenue could offset that, but maybe talk a little bit about how you're thinking of provider rate cuts and what you might expect.
Well, we've seen it before. I mean, we can look to historical in states when there's a recession, or any other kind of deep dive in state revenues, or increase in costs. So provider rates are a go-to. At least in my state, I know it was often the hospitals and the nursing facilities that took it first. If you look at a pie chart of Medicaid expenditures, the big buckets are hospital, physicians, pharmacy, and that's, I don't know, it's a huge chunk of the budget. Everything else is very small. And so you cannot eliminate physician visits and hospital visits. So, but the institutional rates are very significant in terms of the amounts. And so sometimes you will see cuts in those areas. Potentially physician rates as well, just do that. And then anything that can be done on cost containment on pharmacy, states are already pretty aggressive on that, but it's the newer therapies, I think, that are driving that really significant cost increase. And they are, they're groundbreaking, they can be life-changing. They are also incredibly expensive on a per person basis. And so I think states will be looking at that and trying to come up with either collective purchasing strategies. There's been a lot of discussion about different models of value-based types of arrangements there, paying only if the drug works, those types of things that they may have to negotiate with manufacturers. All these things take a lot of time and work for states to do. And frankly, it's just a lot easier to do a percentage rate increase or decrease, because these other things take time not only to implement, but also to see the results. So it's not the most cheerful news, but that is one of the few tools that states have in their toolkit.
I'll just build on what Beth was saying about therapies and just make the observation that with the CMS Innovation Center continuing the access to cell and gene therapy model, that might be one area for states to think about engaging CMS on, to the extent that that is a platform for some of those kind of pooling arrangements and shifting some of the administrative cost and burden and time, to your point, Beth, to the administration, recognizing that it could fit within their agenda. They're endorsing that model. It's active for sickle cell now. A lot of states are participating. I don't know what those therapeutic areas may be, but that may be one area of opportunity.
It's a good call out.
Yeah, and if I could super quick add, you talk about providers and the impact to providers. If you just focus on Medicaid special financing and the provider tax changes, so provider tax revenues drop to a state, they're largely going to impact either hospitals or nursing homes because those are funding rate increases to the hospitals and nursing homes. So let's just talk about hospitals, for example. In the legislation right now, there's a moratorium on new provider taxes. That will affect the rates paid to hospitals. Secondly, there's a change going from the average commercial rate, dropping those rates back down to Medicare levels, which is where they used to be. Some states like Michigan took advantage of the ability to increase hospital payments to the average commercial rate. Bringing them back down to Medicare levels is going to be another hit. And when you talk about rural hospitals, Michigan, a lot of these states have a lot of very rural regions. They're already operating on thin margins. And then you've got people coming in who are not only are the providers going to get reduced in terms of their rates, hospitals in this example, you also have people coming in and now they're going to be, possibly in the country 10 million fewer with coverage. And so now they're taking on that uncompensated care. And so what we're tracking and really trying to keep a close eye on is what that looks like and how we can best mitigate the impact. But right now, when we're talking about the hit, I'm really looking closely at the provider side on the hospitals.
Yeah, that's not going to be welcome news. Let me talk about, we have a bunch of questions on kind of specific access. And Christine, I want to bring you into the conversation here around behavioral health substance abuse services. Several questions about how these cuts will impact access to care for individuals with mental health conditions, et cetera. And it's kind of blends a little bit into health-related social needs, but let's maybe start with behavioral health and mental health needs, and then we can talk more about related issues there. Christine?
Sure. So we've talked a little bit about, just some of the interoperability changes that are forthcoming, because really all the signals are pointing to, the continued push toward integrated care delivery, which on the surface sounds great. But when we start looking at, where the network is to support the behavioral health services is going to be a challenge because, depending on where we land with funding, some of those pieces, especially related to behavioral health services, the medication assisted therapies, especially in rural areas, having the staffing and the qualified expertise in those areas, especially if those cuts impact rural hospitals, will be a challenge. And so really looking at, states and plans to work on advocacy strategies on how to mitigate those things before they occur. Because, really, again, all of the signals are coming to, there's been looking at expanded access to recovery housing and some community-based services. And so really looking at how can, I believe Beth alluded to it, it's going to roll downstream because there's going to be, impacts to the states, which is then going to roll down to the managed care organizations. And so there's going to need to be a stronger partnership than, it already exists in a lot of those places to make sure that the network adequacy measures that are being floated out there are actually something that can be achieved, which then translates into making sure that individuals are getting timely care and just making sure that they're getting the right care when they need it.
So there's questions about kind of benefits related to health related social needs, obviously something that had increased of late. And I know this also sort of touches into waivers, because in some instances those were provided under 1115 waivers. So Josh, maybe I'll go back to you around kind of the waiver specific and the HRSN outlook and what some of the changes might be in terms of coverage and how these services are being covered right now.
Yeah, so my understanding is that the administration, while the first Trump administration did put out guidance on health-related social needs, there is a general view that the pendulum has swung too far to be too broad in defining what can be covered in 1115 and what may be a health-related social need. From my understanding is, there's a view that Medicaid already covers non-emergency medical transportation, that's statutory. Things like food insecurity are often covered by MCOs, and it's seen as cost effective, and so that is not typically needing 1115 waiver. Again, is my understanding of the view. I think housing is an area where a lot of state Medicaid directors and CMS have both had interest and kind of wondered at what point is Medicaid asking to solve problems that are just really bigger and broader and structural and have a lot of contingencies outside of the Medicaid program. So I think one area of unexplored possibility for states is finding areas of commonality around the importance of food and nutrition with an HHS secretary and an administration that, is trying to think about how do you help people live and lead healthier, happier, more flourishing lives. To the extent that that remains a priority and trickles over into the CMS agenda, that may be one area where some, kind of proven models, and here I think emphasis would be on proven models and kind of outcomes, data, evidence, is worth a conversation with administration.
So in terms of the already approved waivers, there's sort of new applications already approved, and then those that are kind of in flight already. Do Liz, I'll ask about,
Sure.
do you see any trends around modifications within current waiver programs, or how, what is that looking like?
Yeah, I think I'm in Washington State, and we haven't approved 1115. There are several states like Washington that have these types of waivers that Josh is talking about, where they're testing out different ways to address health-related social needs or social determinants of health. So I think that's actually good because it can add to the evidence base for future efforts to try to get at these issues. Most of the states that I have been talking with or hearing from right now are just in a holding pattern if they have an approved waiver, because it sounds like if they have an approved waiver, they'll be okay. It's going back and having to get a renewal that is problematic. I do know that states who have approved waivers don't even want to talk about potentially modifying their waivers because they're afraid to open them up. But there's also the whole in lieu of services conversation, which is related to this. I think, trying to figure out how to keep this conversation going, because I think there has been enough evidence to show that addressing some of these things can save money. And if ultimately the goal is to save money, then we should really continue to explore and look for ways to do that. So, but I haven't heard of states modifying things yet. I think they're just waiting to see what happens.
Let's talk about kind of the the brass tacks of implementing all of these changes. There's several questions, including a new one about sort of, if you're renewing every 6 months, what's the ability to process applications at a faster clip? I know there were some previous questions about kind of the capacity, both of CMS as well as, I guess, on states and Medicaid administrations to to make these changes. These are big changes. So am I correct? There's some funding to states to deal with this, but maybe talk a little bit about how you read that. Beth, maybe I'll start with you.
Yeah, there is some funding. I think it's maybe 100 million in one of the versions of it, maybe 200 million in a more recent version. But, that you're talking about $2 million per state, less than that really, because you've got territories in there as well. We used to joke that you couldn't touch our eligibility system for less than $1 million just to even look at it, because they're huge systems, they're very complicated, and sometimes they're very old. And that means that they've got a lot of things that have been put in over the years that are delicate when you start to do major programming. So that kind of money is not going to go very far in systems of that magnitude and changes of that magnitude. So I think it is going to be challenging from that perspective. In terms of just being able to process, for example, processing twice as many applications a year for certain populations. I think you can look to the unwinding of the public health emergency. States had to, they staffed up for that. They brought in temporary workers in some cases to do more administrative type tasks to free up more skilled staff. And so they did a lot of different things. They tried to use things like ex parte renewals, which is just essentially automated data matching to be able to say, can we just determine through data matching that you are eligible and send you a letter saying you are still eligible. Those kinds of things I think are going to have to be looked at again and redeployed to be able to try to absorb this kind of workload on an ongoing basis. In terms of CMS, they are really a very small staff to do the work that they do. And they have had some cuts like most of the federal agencies, although maybe not quite as severe as some others. And so they will be challenged to do the kind of guidance that will be required for all of these, as well as any other administration priorities. So that, I think that this will be challenging. I think states will have a lot of questions and a lot of need for technical assistance. So they do rely on contractors to a certain extent, but whether they will have the time to procure contractors or the money to do that is unknown to me at this time. So, yeah.
So perhaps less resources and as Josh pointed out, less sort of normal rulemaking, so more guidance kind of putting that
That's
out.
right. And I think, some of the ways that you might see that, for example, from CMS would be longer timeframes to get routine approvals, things that are where they don't have a statutory time clock to approve something might take considerably longer, and there's already some indication that those things may be happening already.
I think just to chime in here, one of the things that I'm, flashing back to from 20 years ago here in Washington is when we cut our eligibility period for children from 12 to 6 months, and in 2 years it resulted in 50,000 kids falling off coverage. But the other thing that happened was that there was such a bad backlog. As Beth pointed out, they had to hire all these temporary workers that costed a lot more money in the long run. So I'm just thinking about all the work that, was done at that time to really just document and monitor all of that, because it's important to be able to speak to it, because it is going to come back around. I think we know what's going to happen, and to be able to, demonstrate the impact, but also just kind of the short-term thinking that's going on here. I think it's really important for advocates and providers to be thinking about that.
Well, you can't have any discussion about anything and not talk about AI. So let's talk about, we have a couple minutes left here. I mean, one thing I'm struck with is you've all made reference a couple times to the public health emergency, right? States have just had to go through a period of doing, a lot of things quickly. We know AI innovation is sort of out there lurking more and less productively in some corners. So, Christine, maybe I'll ask you how what's possible here? I mean, are there, not to say that this isn't going to be a big challenge, but are there ways in which, AI strategies or AI deployments may be gaining traction in ways that can kind of enhance or help at least some of the magnitude of what's being asked of states to accomplish right now?
Yeah, so we've been since really the Cures Act, kind of working this digital data pathway over time, really pushing forward with, where we're looking at the digital transformations coming out of the interoperability rules, as well as where we're headed with, the digital quality measure transformation and all of the pieces underneath there. So if you think about just, the administrative pieces, looking at, as we look to further automate prior authorizations, getting a better handle on utilization. So then that way, we've talked a few times about administrative burden. So, the use of AI and, digital strategies to reduce that, not only the burden on the member for all of the paperwork that we've discussed, but really, automating a lot of things where possible to help with the provider pieces, because we've already talked about the rates are insufficient in some cases. And so there's going to be more expected and not a lot of more to add on to adjust for those burdens. And so really looking at, what are those AI driven things that can really enhance efficiencies? And so it's automation where you can prior authorizations, claims pieces, and really looking at, where are the things that can be extracted and really drive, more holistic view of the patient, and then really ultimately reducing turnaround time. So that way you've got a shorter time from the time that the claim enters to the time that the provider gets reimbursed. So then that way they're maintaining their staffs. Predictive analytics, I know, is something that a lot of the managed care organizations have been, dealing with, over time, and are really looking to escalate that where they can. How are they going to be able to use new interoperability capabilities coming out of this wave with, where we're headed with the, API engagements and really being able to hook those pieces together so that way there's more real-time data sharing. So that way it's going to ultimately hopefully reduce the time or allow for more real-time gap in care detection, but then really looking at more targeted value-based arrangements. So that way providers, to compensate for some of those rate pieces, really looking at, is there an opportunity without enhancing administrative burden to really look at augmenting their existing payments through value-based care, moving away from a fee-for-service model and really looking at that outcome-based piece. And so, use of digital to enhance the member churn rates that came out of, the post-pandemic, redetermination cycles, leveraging some of those learnings and whatnot to really drive not only identification of members, but, really create that stickiness because you know where they are even when they've changed managed care partners. And then the biggest piece is going to be, as we talk about the health-related social needs, and really how are we using those predictive analytics, the predictive modeling, to really inform where those targeted community investment strategies might lie? Because then it's really looking at, what is the population being served by, whether it's individual managed care organizations or the managed care organizations pooling together and really looking at, what can our investment strategies be in a state so that way they can drive more holistic changes as they build out their AI strategies and their digital health strategies. Because the more connected everything is, the more chance you have of maintaining that longevity and that longitudinal member record, essentially.
Great. We are down to our last minute, so I might just conclude with a couple things. One, obviously, Farah, you said there's probably a couple of webinars we could do as an offshoot with the complexity and some of the details of each of these topics. So I appreciate the high level, and we were able to hit a lot of topics. It seems that, takeaway certainly is, as Josh opened with, the imperfect certainty that we have and are trying to advise clients what to, where they should respond, what to watch, helping folks to make sense and stay ahead of what will be likely big changes that may have an atypical adoption process or implementation process. So guiding folks through that. Certainly I heard, learning a lot of the lessons from the PHE and a lot of the innovation that's happened lately will be put to the test here as, these larger changes in enrollment, eligibility changes, and ultimately enrollment changes will roll out. And then just thinking about kind of the data environment in which we live and sort of the things that are possible now that perhaps haven't been, understanding how and where plans and states obviously can leverage that most effectively to respond to what will ultimately be significant change in the years ahead. So I thank you all for being with us. Lots of additional questions to answer. Please reach out to any of these folks if you have specific questions. Let us know how we can be useful, and we will continue the conversation in other webinars. So thanks everybody for joining. You will receive a copy of the recording, and look forward to continuing this discussion another time.